I'm the Executive Director of the Illinois CancerCare Foundation, and we are pleased to have you with us this afternoon for this wonderful lecture that really does touch upon an important subject matter as it relates to 1 in 8 women in our country. I'd like to take just a few minutes to kind of describe the flow of how we're going to run the lecture. What I think we're going to start out is having 3 of our 5 panelists actually give formal presentations, and they'll spend each about 5 to 7 minutes doing that. And then you may know on your note on your table, we have some note cards, some 4x6 note cards. We'd like you to use these to write down questions you have as you listen to each of the presenters this afternoon. And I have a number of our advisory board members here, and if I could just ask those to raise their hand. Florence and Terry and Scott. There's Scott. So we'll come around at the break time, and we'll collect these from you, and we'll use them to ask questions when we get to the Q&A session of the program. And then you also have with you an evaluation form, and we'd like you to be thinking about the components of our lecture as you're listening, and be sure to give us your feedback about this program, because it will be very helpful to us as we plan future programs. So we'll ask Drs. Knost and Jalovec and Nancy Donini to make their introductory remarks, and then we're going to take a little break, just kind of a stretch break, get up and get you something to eat and drink, and then we'll reconvene, and I'm going to ask our 2 other panelists to make some comments as they relate to their experiences with hereditary breast cancer, and then we're going to open it up, and we're going to go through the questions and answer the questions that you have for us. Again, we're very pleased. Just going to, on your tables also are some bios for our panelists, and I won't go into a lot of detail about their many accomplishments, but I do want to say just a few words about these folks. Dr. Knost is a medical oncologist and an internist who's been with Illinois CancerCare for 34 years. He has been extensively involved in clinical cancer research for the majority of his professional career. He's held expert appointments with the National Cancer Institute and has served as a principal investigator on numerous cancer research studies. As director of Illinois CancerCare's genetics clinic, he takes a very active interest in hereditary cancer syndromes and the genetic testing and molecular sequencing that are used to identify them. Our next participant is Dr. Lynne Jalovec. Lynne's been a member of our community for over 30 years, beginning in her days as a Bradley student, right? Bradley student here. She's a board-certified surgeon and has really been a pioneer in establishing a comprehensive breast cancer program that we all benefit from here in Peoria. She was instrumental in the landmark Sentinel-Low lymph node biopsy trial, enrolling 150 of her own patients into that trial, putting her in the #1 spot for study enrollment. So that's quite an accomplishment. She has outstanding surgical skill, and along with her warm and caring personality, it makes her a highly sought-out surgeon, with half of her patients traveling from more than 50 miles away to seek her expertise. Nancy Donini is an oncology certified registered nurse who's worked at Illinois CancerCare for the past 9 years. As the genetics nurse coordinator, she works closely with Dr. Knost and Dr. Jalovec in helping genetics patients understand and manage the risks for developing cancer. Nancy is passionate about her work with our patients and is tireless in piecing together their genetic puzzle along with these other outstanding physicians to help determine the best course of treatment for our patients. Both Dr. Knost and Nancy are graduates of the intensive course in cancer risk assessment presented through the City of Hope Division of Clinical Cancer Genetics in Duarte, California. Along with other participants from around the world, they participated in an elite 4-month program that is recognized as the premier source of comprehensive, practice-focused cancer genetics training in the world. We're really fortunate to have this caliber of speakers with us today, and we thank them for joining us. And with that, I think we'll start with Dr. Knost.
that going to work? Okay. All right, let me know. So I want to make 2 points today and make those very briefly, and that is that the technology has changed just within the last 2 years. And with the change in the technology, it's allowing us to do many more things than we could possibly do in the past. This is the way we're organized. We're organized into genes. There's 25,000 of those. They're strung out on 180,000 exons, and there are 3 billion base pairs that are wound around those little orange balls, which are histones, and the histones are put together in little nucleosomes, and then that's put together in chromosomes. You and I have 46 of those, 44 for how tall we are, color of our eyes and our hair, and 2 for boys and girls. Now, in the mid-1970s, we were trying to figure out a way that we could begin to count the base pairs. And there were only 4 base pairs, cysteine, guanine, adenine, and thymine, and they only hook together in 2 different ways. C goes with G, A goes with T. That's the way you and I are built. So, an individual by the name of Sanger said that if there are only 4, then we should be able to assign a color to each one of those. And as those are attached to the single strand, we'll know by the color which one it's partnering with, and we'll be able to read the code as we go down the DNA. And this is how things were done for about 25, 30 years. The problem with that technology is that you can only do about 400 to 500 base pairs in a day's time. When you have 3 billion to go through, you've got to spend a lot of time to go through that. The National Cancer Institute decided in 1990 that they would do just that. They would go through all 3 billion base pairs with the technology they had at hand. And they spent a little over 10 years and under $4 billion to code the first human DNA. Now, there was 2 different competing groups at the time. There was a company called Celera, who was doing it on the private side, and then there was the National Cancer Institute, and they both got together towards the end and put their information together. There were 2 codes that came out, one in 2003, and the one we use today is 2006. So when we want to run up and down the DNA and find where the message is for a particular protein, we have this standard which exists at the National Institute of Health, which we can go to find out what we want to look for. Now, let's take that in myself here. The thing that happened 2 years ago is there's a company called Illumina, and Illumina came up with a different technology, a different way of counting these base pairs, and it's a little complicated. But what they do is they take the DNA and they fragment it into little bitty segments between 100 and 800 base pairs long. And they take these little segments and they run down a little cassette, and the cassette will grab them individually. Now, in the past, the signal from that was very weak and was very difficult to count. So they have a way of amplifying these several thousand-fold around each little piece of information that you want to know. So the technology changed from going to 400 or 500 base pairs in a day's time to going to 150 billion base pairs in a day's time. So where it took 10 years and $4 billion to do the entire human genome project, today you can do the whole genome if you just want the base pair sequence in about a day, and if you want the price for that, it's about $1,000. The interpretation is more, but we've come from 4 billion down to 1,000. We've come from 10 years down to 1 day. So that's what's happened in the last couple of years. Now, what happens when we get the specimens is we usually use blood. We can use buccal mucosa. But we take the blood, we get rid of the red cells by spinning things down, and we take the platelets out, and we use the white cells, we lyse them, we get the DNA, and there's a way to sonicate the DNA to get it down to the fragments that we want. And then we can isolate these particular segments that we're interested in, we can amplify them, we can count them, and then we come up with a signal that we can use to investigate whether or not you have some type of problem or whether you don't. Now, you have to think about this as kind of like we have a library there at the National Institute of Health. It has all 3 billion base pairs on there, pretty much. There are some gaps, there's some areas where the chromatin never relaxes and you're never able to do those sequences, and we're working on those areas. But right now, 2.5 billion pairs we have thrown down pretty well. So when we take a piece of your DNA and we want to find out if you have a particular type of genetic disorder, we know with BRCA1 where it is in that library we want to go and look. And so we take your copy and we can look at the library's copy. And you have to kind of look at it like this. If you had a book and we had a book in the library and you said, why don't you take down your copy of the Bible and you'll see if what I have in my hand is the Bible, and you begin to read the first sentence or so, you know immediately that that was probably the Bible. But yours wouldn't be an actual Bible. Yours would be a collection of papers. And what we would do is we would expand those papers thousands of times, and then we would go through and look at them individually, one at a time. And the thing that can do this nowadays are the computer programs can do that instantaneously. So that's what's changed. Now, when you begin to read these segments, and this is the short segment, you come up with a sentence at the top, which would be basically the signal for a gene, let's say. Now, you don't get the same fragment each time, and you don't get the same fragment each individual. So if these are 5 different individuals, you get basically the same sentence because you're in the same location. But as you can see on the last segment, if you substitute a K for a C, you get the word cat. It's just spelled differently. So when that process occurs, we refer to those as variants of undetermined significance. Sometimes they're also referred to as single nucleotide polymorphisms. And to some degrees, and sometimes they don't make any difference at all, and sometimes they're the difference between why you react one way to a medication and somebody else reacts a different way. The second example is if you substitute an H for a C, then you get a hat for a cat. You get a totally different meaning, and that's truly a mutation. Now, you and I are having mutations occur, or injuries occur to the DNA, which would become mutations if we didn't rapidly repair them. There are multiple levels to repair, but the quickest way, the most efficient way, is called homologous repair. And that is you get 2 strands of DNA, you just go in and clip that out and put in 2 new strands. So, if you think about that, it sounds like, you know, gee, there are thousands of molecules. I don't know how that all works and how things happen, and, you know, it's all over my head. But if you think about changing a tire, when you have a flat tire, you recognize right away that you've got a problem. Everybody kind of knows what the drill is. So there are multiple steps to changing the tire. And if you think about those steps, I don't have to go through all of those, but you understand that there are certain steps in changing the tire that are more important than others. Looking in the rear view mirror to make sure you don't get run down is important, but it might not have anything to do with actually changing the tire. Getting the owner's manual out of the glove compartment is important, but that may not actually get the tire changed. There are things, though, that you can't change a tire without. So these are 4 parts of the repair process of changing the tire that are essential. So in the same respect, in the homologous repair pathway, and this is probably one of the more famous members of that pathway, which has a BRCA1 abnormality. And the pathway, we have a flat tire, which is a DNA damage to the double strand. And what we want to do is we want to pull over the side of the road, and when the cell does that, it goes into the S or the G phase, which is the only period where it can do that because the DNA condenses into the chromosomes and it can get the matching copies together so it can make the repair. And then we call, which is what happens with ATM and the NRM complex. They're basically sending out a signal to recruit more molecules. The red molecule is BRCA1, BRCA2, and those molecules actually grab a hold of the damaged area and help act as scaffolding for the other proteins. Then we have a cleavage of some of the base pairs on the damaged copy. Then we open up the matching copy at the bottom on the 3rd line up. And then we actually change the tire, which is called Holliday's crossover junction. And at the end, we kind of smooth things together and put the jack and the lug wrench back in its place. So in this particular process of homologous repair, there are molecules that are important and there are molecules that are more important. And this represents the group of molecules that are very important. BRCA1 and BRCA2 are essential. That's the tire. Without that, you're not going anywhere. So when you have a problem with BRCA1 and BRCA2, you have a major problem in repairing DNA damage. And that's a problem for you and I because we have at least 10,000 events each day that we have to repair. So with BRCA1, it's breast and ovary. BRCA1, breast, ovary, male breast. Prostate cancer. And in both boys and girls, we have melanoma, stomach, and pancreas. Now, the other molecules there also increase your risk for breast cancer, but they have a little bit different story that's associated with them. As an example, CHEK2 seems to be an association between breast and colon. PAB2 is an association between breast and pancreas. And then you have ones like the MBX1 or NBN, where there's a hodgepodge of different types of malignancy, breast being the most common, but you also have lymphomas, and you have sarcomas, and you have other types of malignancy. There's a lot known about BRCA1 and 2. There's much less known about the others. This is a table that's the work of the University of Washington. It's experience with their first 1,000 cases. Kind of gives you an idea of the breakdown on what we know about at the present time. 10% of breast cancer has a gene that we can go to and say, that's one of the reasons you develop breast cancer. Out of the 10%, about 6% is BRCA1 and BRCA2. As you can see, out of the remaining 3 to 4%, there are quite a few other molecules. And that brings me to my final point, and that is, because of the leap in technology, because we can do 150 million base pairs in less than an hour, we can do on one cassette a series of genes for the same price, for the same amount of analysis that we used to be able to do for BRCA1 and BRCA2. And what's changed in the last 6 months is that all of the gene companies have gone to panels. And this is an example of a panel that you would possibly get if you came and wanted to know whether or not your family was carrying the gene for cancer. So the 2 points are the technology has gone multifold higher than it used to be, thousands of times more efficient. That efficiency has allowed us not just to look at 1 or 2 genes at a time, but to look at panels. These are panels of 18 genes. There are panels out there with 50, 100, 200. I think the future is panels that go to 200 or 300 genes, then you go to whole exon determination, which is 180,000 little bits that make the protein, and then somewhere down the line you go to whole DNA sequencing. So I think that's my 5 minutes. Thank you.
Probably don't need this, but I'm going to put it on just in case. I've never heard anybody say I have trouble projecting my voice. It's probably the surgeon in me. First of all, I want to thank Ms. Barnes for asking me to be here on the panel, along with some very distinguished people who I really, really, really want to thank for bringing us in the Peoria area on a level that I would put with almost any major cancer center in the country as far as providing genetic counseling and genetic testing. We were really doing it somewhat haphazard for many years, and since Dr. Knost has taken over the reins and Nancy's been helping us with this for years, but it is so important for us to have the genetic counseling part of that. And Dr. Knost has been fulfilling that role and has done a fabulous job. The patients come away really understanding better what they can expect with the testing, what a positive test means, what a negative test means, and really the negative test is almost more difficult to talk about sometimes. You know, they assume if they're negative they have no risk. That's not always correct. And you know, it's just really, really been great to have them both working so hard and the people underneath them working so hard to provide this kind of service to the Peoria area. It's just been fabulous. So as a breast surgeon, what I thought I would talk about is the issue of surveillance and the surgical management of patients who have these kind of hereditary breast cancer syndromes. I'm going to ask Dr. Knost at some point, because I did not include in my slides who should be tested. So you're going to have to bring up that issue. You're going to, oh, beautiful, because I was kind of focusing on my area of expertise. So, all very familiar with Angie Jolie. This was the Time magazine cover. From the moment she did this, the awareness of the BRCA gene and people wanting to get tested just skyrocketed. I have to give her a lot of credit. She did not need to be public about this. She could have done this all in private. This is a beautiful woman whose body is part of who she is, as far as she's a talented actress, but we all have to, you know, acknowledge the fact that this very shapely woman has gotten parts because of her shape as well. And she was willing to say, my life is more important than my breasts, and was willing to tell people about that. And she had reconstruction done, and I'm going to show you how reconstruction can be done for people when they do prophylactic surgery, or even when patients have cancer and they find out they're BRCA positive. But I really, you know, feel like she needs a lot of credit for being open out there. It has, don't you think that's made a huge impact on people being aware of this? It's really been impressive. And this was last year, I think in May, wasn't it? It came out. So these are the most common hereditary breast cancer syndromes. Hereditary breast and ovarian cancer is the BRCA1 and BRCA2 mutation. Lee-Fraumeni is a P53 mutation, which is a tumor suppressor gene. Cowden syndrome is another rare mutation that can cause breast cancer and other problems. Peutz-Jeghers syndrome is more commonly thought of as a bowel-type problem with polyposis and an increased risk of colon cancer and other cancers. Hereditary diffuse gastric cancer syndrome also is another bowel-type cancer syndrome, but both of these last two syndromes have a very high risk for breast cancer in them, so I wanted to talk about that. So first we're going to talk about BRCA1 and BRCA2, the carrier frequency. How often can you expect this gene to be seen in the population? 1 in 500 to 1 in 1,000. So this is fairly common, okay? This is not that rare. So we see multiple people a year that are BRCA positive. And since we act as a tertiary care center, we actually see a higher proportion than you would expect. If you happen to have Ashkenazi Jewish heritage, either on your mom's side, dad's side, or both sides even more important, 1 in 40 women will be BRCA positive. So very important to be considered for testing if you have that heritage. So what you see in the box are the lifetime risk percentages for breast cancer in these patients, as well as, on one side, and then what the other side risk would be, and they're fairly high. And what you notice is that there's quite a range. So very similar with BRCA1 or BRCA2 as far as breast cancer. Contralateral breast the same. Ovarian cancer is slightly different. So again, it's primarily a breast and ovarian cancer abnormality, but you do see male breast cancer, you see other cancers like pancreatic cancer, like Dr. Knost mentioned, prostate, melanoma, and gastric cancer. The issue, I lost my train of thought, we won't go there, I guess. The male breast cancer issue. A lot of people talk about male breast cancer, and since it's relatively rare, it's about 1/100th the amount of breast cancer that we see. So if we see 700 breast cancers a year in Peoria, we would expect to see usually about 1 or 2 male breast cancers a year. That's it. Okay? As far as how we manage these people, so if someone is found to have the BRCA1 or BRCA2 gene, because their breast cancer risk is so high, we do recommend that they start mammogramming at an earlier age. What wasn't discussed, and it's just in a simplified version, is the concept that you have 2 copies of the gene. If you are born with 1 copy not functioning, it takes less time for you to have mutations that occur in that remaining gene so that it does not function also. And once the 2 are not functioning, we have a problem, okay? So if you have to screw up 2 copies, if you want to think of it that way, it takes longer to do that. So regular breast cancer takes longer to occur. Average age, 60s. The average age of someone with a BRCA mutation is going to be much younger. Typically, we're talking about people under the age of 50. And some of them are 20, 30, even 40-year-olds, will have BRCA positive, when they come about with cancer. So it's important to understand that we do start looking at these people earlier. This recommendation, which comes out of the NCCN, recommends that you start mammogramming at age 25 and having annual MRI studies done, also alternating between the 2 at the beginning about age 25. Now, the rest of us will not qualify for getting yearly MRIs because an MRI is a very expensive test, $6,000 for this test. And they reserve it. The guidelines for the use of this, as established really by the American Cancer Society, came up with the guidelines for MRI use, and we're following this, is you have to have a breast cancer risk of about 25% or more. And so the average patient does not have that risk. Our risk for breast cancer is about 12% by the time we get to 90, 100 years old. So we don't qualify for yearly MRIs. It's a very, very sensitive test, but not as specific. So people that have the test end up going down the pathway of having a lot of extra workup, extra biopsies done. But if you're at high risk, it would be worth it to do that. Clinical breast exam every 6 months by a clinician, doesn't have to be a doctor, nurse practitioner, physician assistant, anybody who's skilled at a breast exam is good. You should do your own breast self-examination, although a lot of people feel that it creates so much anxiety that it's not worth it. I don't know, I think you ought to know your body, so I personally think you ought to do your breast exams. The other issue that I need to talk about just briefly is the use of prophylactic mastectomy. So patients that do carry these abnormal genes have such a high risk for breast cancer that they are considered, and insurance companies will pay for prophylactic surgery along with any reconstruction that needs to be done. So this is something that the insurance companies are quite willing to pay for because they know that they are better off preventing the disease than having to treat someone once they get breast cancer. Chemoprevention can be considered, although it's maybe not effective in all BRCA-positive patients. Most of us, in the chemoprevention trials, it looks like it does lower the risk for breast cancer in these patients, but a group of patients that we think it probably doesn't help are the BRCA1 patients that are what we call triple negative, meaning they develop breast cancers that are not hormone sensitive. Tamoxifen is a drug that helps lower your risk for breast cancer in women that already have a breast cancer that is hormone sensitive, or it basically reduces your risk for only hormone sensitive cancer. Okay? Ovarian cancer, not great screening tests. What we've found over the years is that doing transvaginal ultrasound and doing what's called a CA-125 blood test, looking to see if there's elevation of that test to indicate an ovarian cancer, can be helpful, but it can all be normal and people can still have ovarian cancer and even advanced ovarian cancer. So when someone tests positive for these mutations, we do recommend that they consider having their children soon. You don't wait till you're 40 to have your children. If you can have them sooner, we recommend that. Once you have had your children, then the question is, when is the right timing for prophylactic surgery? If you have a series of people in your family that have had breast cancer, but there's no ovarian cancer in your family, it's likely that you're not going to get ovarian cancer either, and you could probably delay your removal of your ovaries until a little closer to menopause, so you don't get side effects from losing your ovaries that early, such as more osteoporosis and things like that. But certainly if there's, like Angelina Jolie is like on a timeline here to get her ovaries out, because her mom already had ovarian cancer, I think, by her age. And her mom died of her ovarian cancer. So she is right now, the word is out that she's waiting to decide if she's going to have one last baby and then have the ovaries out. But she needs to get them out soon here. So it's really an individualized recommendation. We usually have them see one of our gynecologic oncologists, and they help them decide where they're at in their menstrual health and things, and makes a decision exactly when would be the best timing to remove the ovaries. If, just like every one of us, there is some benefit to using birth control pills in lowering your risk for ovarian cancer. You guys may not be aware of this, but if you took birth control pills in your lifetime for 5 years, you lowered your ovarian cancer risk by half. So that's one good thing. And it appears that using birth control pills, even in this setting, can be helpful for those patients as well. So before they want to have children, we recommend birth control pills. They have their children, and then once they're done with their children, we consider removing the ovaries and the tubes. The uterus is not critical, but the ovaries and the tubes are where the cancer likes to occur. Male breast cancer, same kind of follow-up. Breast exam every 6 to 12 months, and we consider mammograms. Now, they do not talk about doing mammograms on these people regularly, because I think they somehow think it's so difficult to do a mammogram on a man. It's not. If they carry the gene, I'm mammogramming them every year, and I do have some patients that are BRCA positive that I follow. So there's no reason why you can't have a mammogram every year. We just send them over to the breast center first case of the day, so they're in and out. But you know, when you go get your mammogram, there's all sorts of men in the waiting room, so how do you know? You know, they don't know that they're having a mammogram. And then pancreatic cancer, even though this says no recommendation, there are some things that can be done. If there's pancreatic cancer in your family, and you're BRCA positive, and your family member was BRCA positive, then they can do something called MRI, cholangiopancreatography, and that may be helpful in finding an early pancreatic cancer. There's ultrasonography that can be done endoscopically to try to look for it. So there are some things, but they are not established as working that great. Just to show you a mammogram, up on the top, do you notice the two differences in the mammogram? The top mammogram is the old style mammogram, the bottom is the digital mammograms. Okay, so we're getting better and better at doing mammograms. If someone has questions about the recent article about mammograms, again, you can ask me later. Because nobody heard about that on Monday or Tuesday? Yeah. Now they're bad-mouthing mammograms again. They all want you guys to have mastectomies when you find your cancers. You know, like you're going to find them early if, you know, so the idea of breast conservation is just totally negated by, you know, they don't want you to find it early, I guess. This is what spot magnification shows on films, that these are actual cancer films. So you can see, we see it pretty well. And this is a small cancer. This woman has a 90% plus chance of survival because she had a mammographically detected lesion. I don't know about you, but that's what I want. This is what an MRI study looks like for us, and it shows up as a hot spot here. So you get a material that allows an area to enhance on the scan, and that also, this is the spot here and over here. These are slightly different positions in the breast. So it really does help us quite tremendously to see things in the breast that we might not see real well on a mammogram. This is what a prophylactic, nipple-sparing total mastectomy looks like on both sides. So she has had both breasts removed. Yep. Nipples all look normal because they're her own nipples. So we don't have to take away the natural skin of the breast in order to get rid of their cancer risk. We basically make an incision underneath the breast here, underneath it, take out the glandular tissue, and it is replaced by an implant in most cases. So she has bilateral implants in place. Her scar, there's a scar like right here. You can just see the edge of it over here. So we can't do this, and Angelina Jolie had hers done this way, I'll bet. In most cases they do. So this is, not everyone is a candidate for this if you have very, very large breasts that droop, but women that have more average breast size can be considered for this. So what is the benefit of doing the mastectomy? Have we proven that doing a mastectomy on these patients will prevent breast cancer? And the answer to that is yes. There was a very good study, probably 20 years ago, by Lynne at Mayo Clinic, that looked at prophylactic mastectomies and then went back and looked at whether these people were BRCA positive or not, or whether it was just strong family histories and things. And they found that you could reduce your breast cancer risk by 90% in those patients. Remember, they have anywhere from a 55 to 85% risk of cancer, and you reduce that by 90% if you remove the glandular tissue. Another thing is, if you just have your ovaries removed, and say a woman's not ready to have her breast removed, maybe she's single yet, or she's divorced and she feels uncomfortable with the idea of losing her breasts and being out there in the dating world and things. So we do have good tests to watch the breast. We do have that MRI test that is really very good at picking up cancer. So it's not likely a woman would be found with advanced cancer. So breast screening is pretty good. Ovarian screening, not so good. Are you getting that? So say she doesn't want to do that, but she'd like to lower her risk for breast cancer. She can do that by having her ovaries removed. You reduce your breast cancer risk by 68% just removing the ovaries. Why? We make you menopausal. We take away estrogen stimulation. All right? And then if you do an oophorectomy, of course that's removed for you guys, it's removing the ovaries. We always got to have strange language. Have you ever noticed that? Can't have simple language, just like the lawyers. So an oophorectomy done will lower the woman's risk for ovarian cancer by 96%. Okay, nothing's 100%. You can't actually get ovarian cancer when you've had your ovaries removed. Sometimes we have a little bit of ovarian tissue in other places in the pelvic area. When you were developing, some of the cells moved out of the ovaries. But by and large, it really reduces it tremendously. So another common mutation, or not that common mutation, but one that is spoken about is this Lee-Fraumeni syndrome. And as I said, this is a P53 gene mutation. It's autosomal dominant, meaning if you have, all you have to do is inherit one gene, and you will have symptoms. But interestingly enough, 20% of these patients are the first mutation. So they are the ones who are developing the mutation, not getting it from their parents. The predominant features are early age onset of malignancy. So they have really large numbers of people with cancer in their family oftentimes, and young. A 20-year-old with bone sarcoma, another one with a sarcoma of the kidney or something. Very weird cancers and things like that. 50% of the patients with this gene mutation will have their first cancer by age 30, and 90% will have some form of cancer by age 50. There's a wide variability of expression, so there's a fairly large number of different cancers you can get, breast being one of them that they talk about a lot, but it just depends on the way your gene abnormality is, whether or not you're going to get that particular problem. Nearly 100% lifetime risk for cancer occurs in females, slightly lower than that in males. Here are the different kinds of cancers. You see that breast, the reason I talk about it is breast makes up 24% of their cancer. And then you have bone, brain, soft tissue. These are sarcomas, a type of cancer that occurs in soft tissue. And then you have much less as you go down the road, as you can see on that. And then when you look at ages, look at how young some of this happens. The very top one is, and this very first bar here is like 0 to 9 years old. So adrenocorticoid tumors can occur in very young children, and so pediatricians have to be warned if there is leaf-Ramini found in the family, then they need to be told about any of the children of those people. Even if they've not been tested yet, you want to keep a close eye on them for childhood malignancies. Soft tissue sarcomas, again, you see a big spike in young age. A little bit older for bone sarcomas. With brain, it kind of goes throughout the age group. Breast tends to happen in the 30s, late 20s to early 30 range is the most common ages for that. What do we do for these people for surveillance and risk reduction? Again, clinical breast exam every 6 to 12 months, beginning at age 20. Between 20 and 29, we start with annual breast MRIs. We do not start with mammography usually that early, although if a patient has a lump, we will do a mammogram on her. Why don't we start that early with mammograms? There's something about, maybe Dr. Knost can tell me more about this, there's something about this mutation that makes them sensitive to radiation, so that we don't want to give them any extra radiation to maybe prompt a problem with cancer. Now, by age 30, we want them to have mammograms. So even though there might be an increased risk, we do want them to start annual mammograms, alternating with an MRI. So every 6 months, they get something done. Over 75, if they haven't had breast cancer by then, there's a good chance they won't. And then, of course, we discuss risk-reducing mastectomy with this group of patients as well. With other types of cancer in leaf-Ramini, there are limitations on what we can really check. You know, how are we going to look for these unusual cancers? They recommend that you carefully look at their skin for problems, do neurologic exams. They recommend we avoid therapeutic radiation. So if a woman with leaf-Ramini gets breast cancer and she says, I want to keep my breast, which some women with genetic mutations do that. In this particular case, we would caution her against that very strongly. Because again, radiation for these people seems to increase their risk for cancers rather than control the cancers. Colonoscopy is recommended every 2 to 5 years beginning at age 25. So these people really are destined to do a lot of screening. Again, the pediatrician should be warned. We talked about that. Whole body MRI is something that's being explored. And we kind of base the surveillance on what kind of cancers are in the family. If there's a lot of colon cancer in the family, you make sure you get started at least 5 to 10 years with your screening, 5 to 10 years earlier than the youngest person in the family with cancer. So we backtrack from the youngest person in the family. This is Cowden syndrome. And I don't know if you can tell, but there are these little bitty bumps here on the mucosa here, and then these little hair follicle problems. They're oral papillomas and these tricholemomas. These are some of the external symptoms that these people have. It's a rare disorder, 1 in 200,000, and I actually have a patient with Cowden's. So, autosomal dominant, again, P10 mutation, which again is a tumor suppressor gene. Hamartomas are common. These are benign growths that occur from an overgrowth of normal tissue. And it can include other clinical symptoms. Macrocephaly is an enlargement of the head, mental retardation and learning disabilities, arteriovenous malformations, and benign breast disease are all seen. The risk for breast cancer, pretty significant, 25 to 50%. Again, normal risk for our entire lifetime is typically about 12%, 1 in 8. So these people have a significant higher risk. They do qualify for things like MRIs. Thyroid cancer is seen, and this patient had thyroid cancer as a young person, and I'm following her for breast cancer risk. Colon cancer, endometrial cancer, and other benign lesions. There it goes. It took a nap. So we start breast awareness with doing breast self-examination at age 18, the clinical breast exam, mammograms beginning at least by 30 to 35, but if they're having breast complaints, like my patient, she's getting mammogrammed earlier, and for sure breast MRI is what we're doing. On a young patient, I would favor doing that and maybe a mammogram as we need to, till they get a little bit older. And we discuss risk-reducing mastectomy and hysterectomy when they get old enough. Physical examination needs to be done on these people. Comprehensive exams should be done. Thyroid ultrasounds need to be done. Colonoscopy, renal ultrasound. Peutz-Jeghers syndrome, again, this is more commonly thought of as a small bowel colon-type polyposis problem. But look at the incidence of breast cancer. If you have this mutation, you have a high risk for breast cancer. And that's not something that people usually, I think, talk to them about as much as they should. And you see all of the other incidents of bowel cancers here. So there's a lot of different cancers associated with this. With breast surveillance, all the same stuff. We just start the mammograms and the breast MRs a little bit earlier at 25. And we do discuss risk-reducing mastectomy. Colonoscopy, upper GI endoscopy is done on these people beginning at age 18. They start looking at the small bowel. At age 8 to 10, they get their first screening, and then every 2 to 3 years by age 18. Annual pelvic exams beginning at age 18. And I mentioned something about this cholangiopancreatography MR study, or an endoscopic ultrasound every 1 to 2 years to look for pancreatic problems. Then lastly, there's this hereditary diffuse gastric cancer syndrome where people get gastric cancer at a high rate, but look again at the breast cancer rate, 40 to 50%. So we do want to keep in mind that we have to, monitor for breast cancer in these patients. The thing about the gastric cancer is the screening, again, not so great. In prophylactic gastrectomy surgery on these people where they did not know they had cancer, 74% were found to have cancer when they looked at the stomach, under the microscope. So these people are actually strongly recommended to have the stomach removed before anybody finds any cancer. Breast MRI and mammography starting at age 35. Strongly consider total gastrectomy by age 20. So in summary, genetic risk assessment for hereditary cancer is integral in the comprehensive care of today's patient. Referral to a genetics clinic which provides for genetic counseling as well as genetic testing is preferred. So you'll see a lot of doctors sending everybody for genetic testing. And I've had some doctors say, I can do that test. I don't know why they send them to the genetics clinic. Unless you are prepared to talk to them about the results of that study, you should not be doing the test. Okay? And that is not just my opinion, correct? That is the opinion of all of the major players in genetic testing, including the genetic places. Consultation with the ones doing the actual test prefer that too. Consultation with the appropriate surgical specialty should be done for possible prophylactic surgery when it's indicated. Follow-up with these patients with a known mutation or in those who test negative but have strong family histories should be done by a clinician who is familiar with the problems associated with this pattern of genetic abnormality. Sources for additional information are seen here, and this is Greece, Santorini. So I'll give you guys a chance to ask some questions a little bit later, and I'm sorry I went over my 5 minutes way long anyway.
I'll make up for Dr. Jalovec and be quick. Dr. Knost basically started this clinic October of 2012 in earnest. So from October 2012 till now, we've seen over 496 new patients, and that's just doing genetics a couple days a week. Lately, it's been hard to just do genetics a couple days a week. We have a hard time fitting them in on Wednesdays and Fridays, so we'll see how that goes. Of those 496, so far, 404 patients have returned for their test results and further counseling. Every now and then, somebody's test doesn't get run, or the surgeon has had to give the results because it was urgent. So, pretty good track record so far. Now, of the 496 patients we've seen, over 80%, or approximately 80%, have been breast patients. So, a large percentage of the patients we see, the concern is breast and ovarian. Now, just this year, we've seen over 90 new patients, and 117 have returned. So some of those are left over from the previous year. We like patients to come twice. We like them to come and sit down with Dr. Knost so he can go over your family history, so he can examine you. And some of the things Dr. Jalovec just talked about are reasons why the doctor should examine you and why a doctor shouldn't just order a test. Because one of the tip-offs for Cowden syndrome is you'll see Dr. Knost measuring the patient's head. Larger head circumference can be a tip-off for Cowden syndrome. Dr. Knost is going to look at your skin because there's skin abnormalities that can go with certain genetic mutations, so it's important to see him. Then it's important to come back, because even if your test is negative, that doesn't mean you don't have any risk, and that doesn't mean that he's not going to have some recommendations to help you stay healthy. We get our referrals from many places. Breast surgeons are by far our biggest referrals. Dr. Jalovec and Dr. Manuelito keep us in business. The breast center sometimes screens the patients before they get to us. Colon surgeons are more and more giving us more referrals. The gynec surgeons who are in our practice often see patients and refer them on to see Dr. Knost. The other medical oncologists in our practice make referrals. The OBGYN offices. A lot of family practice physicians have been making referrals because the medical community is becoming more and more aware of the risks that people have and that there are things we can do about them. And then patients are getting more savvy, and we're getting a lot of self-referrals. And those are all perfectly acceptable ways to come in and be evaluated. Anyone who has questions about their risk for breast and ovarian cancer, or any other cancer for that matter, is an appropriate referral. You don't necessarily have to be tested. Sometimes you just need to discuss your family history, your history, and Dr. Knost will advise you, this isn't a case where you necessarily need testing, but you do have risk. Everybody has risk. Risk can be things like how old you were when you started your period, how old were you when you had your first child, are you overweight? Those are all things that play into risk, and some of that has a hereditary component, but some of it is things we can control too. Like we can control our diet a little bit, our weight, exercise. Those are all things that can help reduce our risk, and he'll talk to you about those as well. What constitutes a referral? How do we get our referrals? Or what would make us want to test you? Well, we have guidelines. We use NCCN guidelines, and we use the Medicare guidelines. And I'm not going to go into all the nitty-gritty, but a lot of people don't know that somebody with triple-negative breast cancer, that's breast cancer that's ER/PR negative and HER2 negative, if they're under 60, they should be tested. So that's an automatic referral that a lot of people don't even know. If you're diagnosed with breast cancer under the age of 45, you should be coming in to see us. There's just lots and lots of different ways that I'm not going to go through every single guideline. Then if you're a Medicare patient, Medicare has strict guidelines. You either meet the guidelines or you don't meet the guidelines. If you meet their guidelines, they'll pay for your testing 100%. If you don't meet the guidelines, they won't test you at all. And in a lot of ways, the Medicare guidelines aren't fair. A lot of men need tested because of a huge history of prostate cancer in their family. But if that man does not have breast cancer and he can't have ovarian, they won't test him. So that needs to change, but for now, Medicare has, the guidelines are if you're diagnosed less than or equal to 40 years of age, automatically you can be tested. If you have breast cancer under the age of 50 or 2 breast primaries and you only need one other relative diagnosed, one of them should be under or equal to the age of 50. And then if you're diagnosed with breast cancer at any age, you just need 2 other relatives, and they're not that picky on how close those relatives are. So we do manage to get a lot of Medicare patients tested, and we are finding people who are well past the age you would think that the genetic mutation would cause them to get cancer, who do have a BRCA1 or 2 mutation. So, you know, just because you're over 50 doesn't mean that you shouldn't be evaluated. We're hoping that this helps all of us a little bit. The Affordable Care Act requires insurers to cover genetic counseling for BRCA testing as a preventive service with no patient cost sharing. So you should be able to see providers such as Dr. Knost and not have to pay a copay, and it should be covered. A lot of people have wellness benefits too that should cover this, and again, you shouldn't have to have a copay when you come in for your visit. As far as the testing goes, we submit your sample. If testing is in order for you, we would submit your sample to the genetic testing company, and we have 2 or 3 companies that we kind of favor. They are very, very savvy at working with your insurance company. They'll hold your sample until they're sure the test is covered. And then if the test is not covered, they'll call you and tell you that and give you an opportunity to cancel. So just because we send off a specimen doesn't mean they're going to run the test and doesn't mean you're going to get a big bill. 2 of the companies we use notify you if you owe more than $100. So the only risk you're assuming by letting us test you is $100. The other company notifies you if you owe more than $375. And considering the test can be well over $4,000, that's pretty good. The risk models, Dr. Jalovec touched a little bit about, you know, what qualifies you for an MRI, what qualifies you for testing. A lot of times when Dr. Knost sees you, he'll do the UPenn 2 model, the Myriad model, and sometimes Klaus, and those give numbers that he can use to justify testing. And a lot of times that's enough to convince the insurance company this patient has enough risk that they should be tested. Say that you come to us and you don't have breast cancer, but you qualified for testing, and we tested you and you're negative. Well, you still have risk. And so, like Dr. Jalovec was talking about getting you qualified for an MRI, or whether you should take tamoxifen or Arimidex or Romacin, we would use the Gale model.
Presentation here. The first is Ann Best. Ann is a director of the Illinois CancerCare Foundation Board, and she's also a former chairperson for our Courageous fundraising event that we hold each year. She's also a patient, and along with a number of members of her family, she has experienced the genetic screening process for hereditary breast cancer, and she's going to talk a few minutes about that. Also joining us is Angie Earles. She's a research educator at Illinois CancerCare. She just celebrated her 14th anniversary with us, and she thoroughly loves working with our patients and helping enroll them in clinical trials, a number of them which are in the area of breast cancer and prevention. And so she's going to talk a little bit about those trials as well. And then as soon as they're done making some introductory remarks, we're going to move right along to the questions that you have. And I think Nancy's kind of reviewing those. So if anyone else is still writing questions, feel free to just bring them up and we'll move on.
I really didn't have a lot of remarks prepared. I will just tell you briefly what my experience was. And my sister, who's here in the audience as well. I was diagnosed in 2002 with breast cancer. I grew up knowing that that was a strong possibility because my mother was a breast cancer survivor of many years, and she had had a couple of reoccurrences and had several aunts. So that left my sisters and I feeling like the probability was strong that we would at some point in our lives develop breast cancer. My sister was diagnosed first in 1999, I think. I think she was 39, and I was 42, just a couple of years later. And you know, you're never actually prepared to hear those words, even though you think you are and you know you have a strong family history. It took several years for Maggie and I to go back, hearing a lot about the genetic testing and what that might mean for us. We knew it was important because we had children, and we wanted to be sure that they were given every opportunity and every tool that they might need to make decisions for their futures. So in 2008, Maggie and I came into Illinois CancerCare, and we met with Nancy for quite a lengthy session with her and talked about our risk for being positive and what that might mean for our children if we were. We left there saying we wanted to talk the decision over with our husbands. Went back. It took 5 months for that discussion to evolve. And then went back in December of 2008 and got tested and was positive for BRCA1. And my sister is also positive for BRCA1. And when that occurred, we both sort of took a step back and said, okay, what does that mean for us now? The one thing sitting in the audience and listening to everything we said, the thing that struck me is how scary it sounds. It was really nice to hear Nancy get up there and say, you know, we want to help you stay healthy. The purpose of the genetic testing and the screening and recommendations is to keep you healthy and help you make the best decisions that you can about your care. And basically that's kind of it. I think one of our struggles in being BRCA positive and looking at what we need to do in the future was, what does that mean for our kids, and especially my sister who has daughters. And you can get tested so much earlier now. I think the thing that we're trying to keep in mind is that this is a positive thing, that we have so much information available now that wasn't available even 10 years ago. And my own question even was getting tested in 2008. I think there's probably so much more they could find out even now at this point. Things have changed so much. So for us, it was just kind of getting in the mindset of getting the most information we can to make really good decisions, to make sure we have good counseling. And the fact that we have it right here, and Nancy and Dr. Knost is really invaluable. It's been really important for us.
I'll just be really brief too, but I want to put a huge plug into the clinical trials that are also going on here in Central Illinois and have been going on for quite a long time, since 1978 when the practice was started. The founding doctors, and it's continued through the physicians today, is the emphasis on research. Not just for only the treatment, but also for the prevention. One of the trials that they mentioned earlier when introducing Dr. Jalovec was the sentinel lymph node surgical trial, where many patients from Central Illinois helped to be part of that trial and helped to shape how surgeries in breast cancer patients are done. We have breast cancer. They also mentioned the prevention trials with including the drug tamoxifen. Many women from Central Illinois participated in those trials to determine whether tamoxifen can be used as a prevention drug. We have prevention trials going on today with looking at vitamin D in higher risk patients with that are healthy patients but have a higher risk for breast cancer. Then we also have the treatment trials. Currently, we have approximately 13 active trials open in breast cancer. If at any time you want to go out and look at our website, it will list our trials. We look at from the early, treatment trials with just chemotherapy, and I'm sure a lot of you have heard the words about targeted therapies, and how now with the help of the genetic testing, it's going to become even more personalized. And we do have some genetic breast trials and looking at also not only for breast cancer, but for other cancers as well. And I wanted to point that out because it is a huge, huge thing here in the community and has been very helpful for those patients who have been diagnosed with either cancer or for those prevention trials.
All right. The first question was, I tested negative on my genetics test. Would it be advisable for my brother to be tested to see if he could have a BRCA abnormality? And could he pass it on to his children? And my mother had ovarian and I had breast. This brings up 2 points. One is, it depends on when you had your genetic testing. Up until last May, the only company that was doing the BRCA1 and BRCA2 was the Myriad. They had the patent on it between 1996 until 2013. And they controlled how the test was rolled out and what they would do and what they wouldn't do. And for several years, they made the claim that the BART testing, I'll explain that in a minute, was only prevalent in Latino populations, very heavily breast and ovarian positive. And so women didn't get routine BART testing. As they began to look at it in a broader fashion, it turns out that 10% of BRCA1 and 25% of BRCA2 are BART positives. So if you had your breast testing prior to 2012, you probably didn't have BART testing, so you probably want to come back and make sure that that portion of the BRCA1 and BRCA2 is negative. So what does BART mean? Well, there's 2 ways to have a mutation. One is a spelling problem, the hat versus cat, and those are mutations that have been done since 1996. The other possibility is that the word cat is completely missing from the DNA code, and that's called a large rearrangement. And so the process of looking for large rearrangements is called BART. And the question about the brother, it is possible for the brother to carry the gene and not express it. Certainly in BRCA1, that's the case. There may be a slight increased risk of breast and prostate in them, but by and large, men carry BRCA1 and don't express it. So I think that that's 2 points out of that question.
All right. Thank you. All right. One of the questions here was, the person said that they understand that radiation can cause cancer, and how can all these recommended mammograms not increase the risk for breast cancer? There's been a lot of, those of you who have paid attention to the news in the last few days, heard about another review of mammography data to try to determine whether or not the use of screening mammography is worthwhile. And they keep trying to use very old data, poorly done tests, and you guys have probably heard the comment for computers, garbage in, garbage out. If you are reviewing poorly done studies, then your answers are not going to be proper answers. So those of us who work in the field and deal with current ways of doing mammography, which is more, we're talking in the last 10, 20 years, some of these studies they're looking at, we're doing studies back in the, really old, we're talking 30, 40 years ago some of these studies were started. And what we do today is not at all what they did back then, and how they read them and who read them, the expertise of the readers, etc. Now, getting back to the radiation question. Years ago, 30, 40 years ago, you got a fair amount of radiation with mammography. Nowadays, a standard mammogram is going to give you much less radiation than a simple chest x-ray. If you fly on an airplane once a year, you're getting more radiation to your breast than you're getting on a mammogram, okay? Because of, once you get up above a certain layer, you start getting exposed to radiation in the atmosphere. Sorry, but you do. So it's a lot less than you think it is. There have been some talk when they review things that there is an increased risk of breast cancer in women who have mammograms. The problem with those studies are those women were not randomized to getting a mammogram. They were just observed. So who do you think goes for a mammogram sometimes? You feel a bump in the shower, I got a problem, I'm going to go for a mammogram. That's not a screening mammogram. It may have been listed like that, but it's not an actual screening mammogram. It's a diagnostic mammogram. They're going in for a problem. So when you look at randomized studies where people are not given the choice of coming in for a mammogram based on something they're feeling, there does not appear to be an increased risk of breast cancer associated with doing screening mammograms. When it comes to the issue of radiation-induced cancer, the BRCA gene patients do not appear to be at increased risk. So they are recommended to still have mammograms done along with the MRIs. Now, why are we doing two different tests? Partly because the MRIs do not see what are called calcium deposits. Calcium deposits in a certain pattern on a mammogram can indicate the beginning of breast cancer. And if you're a BRCA patient and you have not done prophylactic surgery, do you want to catch your cancer like really early? Then you need a mammogram, okay? Because those calcium deposits may indicate the beginning of non-invasive breast cancer, which is near 100% survivable. And you could take the opportunity at that point maybe to decide to go ahead and do your mastectomies at that point and not harm yourself. So from the standpoint of radiation in a BRCA patient, they are allowed to do breast conservation. And I have some patients who were found to be BRCA positive after they had had their cancer treatment years ago. And they were offered having their breasts removed, and they've done fine, and they've chosen not to do that. I'm following them with mammograms and MRIs. So it is an acceptable option for them.
I'm just
Okay, this one has, how do you determine if you're at a higher risk for breast cancer before doing the breast genetics testing? And we mentioned the 25% figure. So there are two possibilities. You either don't have breast cancer or you do have breast cancer, okay? And so if you wanted to determine if you have a family history and what your risk is of developing breast cancer, we utilize a different model than if we're going to try to determine if you have a BRCA or a genetic abnormality. So if you don't have a history of breast cancer, then we utilize, and you do have family members that may have had breast or ovarian or other malignancies. We use models such as the IBIS model. You can use the Gale model. You can use the Klaus model. There's a computer program called BRCA Pro, which does several of those at once. These models have been worked out, some based upon population studies, others based upon mathematical calculations. But they're fairly standard throughout the genetic world, and they do give you a probability that you'll have breast cancer at any point in time from your age until usually 70 or 90 years of age. You're set up on different timetables. The second was if you lose your current health coverage and something changes in the Affordable Care, how will you be able to get new insurance? Well, since since 2002, the federal government passed a law in which you cannot be turned down for health insurance because of a genetic abnormality. So if you apply for insurance and you have a BRCA1 or BRCA2 or RAD51C or whatever, you cannot be turned down. It doesn't hold for life insurance, but it does hold for health insurance.
So as Dr. Knost said, if a young person is thinking of getting BRCA testing done, now certainly if you have breast cancer, it's not an issue because I hate to tell you, but life insurance companies don't like you if you have breast cancer or any kind of cancer. But say you're a young person and you knew your mother had breast cancer, she was never tested, and you're looking into getting testing done. You want to make sure that you get your life insurance. If you're thinking of increasing your life insurance, you want to do that before you get your testing done. Because they do have the right to ask that information. They ask complete health information to make a decision on the premiums. So you do want to get that done ahead of time.
Next is what causes the good BRCA gene to fail. So the gene actually doesn't fail. What happens is that when you want to create a baby, and I say this all the time, you start out with an egg and a sperm, and in your body and my body, there are 13 trillion cells, and those 13 trillion cells have 46 chromosomes. But when you want to create a baby, you don't want the baby to start out in life with 92 chromosomes, okay? That doesn't work. So as the sperm is getting down to the last cell division, as the ovum is getting down to the last cell division, it makes a conscious choice between whether to suppress one set of genes or the other. So the ovum contributes 23, the sperm contributes 23. As you're making the decision to go from 46 to 23, going down to 25,000 genes, you consciously make a decision about going to suppress moms and express dads and express mothers. If you suppress the BRCA mutation and provide the good gene, that child has the same risk of cancer as anybody else in society. If that decision turns out that the good gene is suppressed and the BRCA gene is provided, then that individual has all the risks associated with BRCA1 and the other genetic abnormalities. This kind of is
The question was, if you're BRCA positive for a mutation, at what age would one have prophylactic mastectomies? Really, it's dependent on the patient. Most of these patients are not getting tested until about age 18. It's pretty much, considered appropriate with this particular type of genetic abnormality. Now, if you have a family history of 10-year-olds with cancer, that may be different. But certainly for BRCA mutations, most of the mutations we're talking about here, we tell people that we do not recommend their children be tested. We recommend that they be tested once they become adults. So they have an active participation in the decision-making to have the test done. So they're going to be 18 or more before they're going to find out that they're BRCA positive. What we do is we see them and we start counseling them on what they can do to lower their risk and how they can do screening. And we talk about the screening schedule and things like that. If they ask us about prophylactic surgery at that point, because we bring it up, but really there aren't too many 20-year-olds having prophylactic surgery. If you remember, we have an idea when most of these cancers occur. In the BRCA patient, we don't see that many that are literally 20. But we do see people in their late 20s that are developing breast cancer. And the earliest I've done a BRCA positive patient, I think, is about 28. And the reason she decided to have it done that young was her sister had breast cancer at that age when she was pregnant and did not do well. And so her sister tested positive. She ended up having the test done and was positive. And she came to see me and said, I'd like to have this done sooner than later. So it's a discussion that you have about the pros and cons of what this is going to do to your body image. You do lose complete sensation of the breast, so there is no sensation of those nipples, even though they look good. And not all of them are going to look as good as that patient did. They do tend to look very good because we're not, if it's all prophylactic, we're not dealing with a cancer. And so we're not dealing with radiation a lot of times and other things that might have to be added. So they, in general, look pretty good. And, I think we just emphasize the importance of an individual program for every patient, because some families have early cancer, some have more later cancers, they have more ovarian in one family, more breast in other families. So we work together as a team to try to help them decide when would be the best time to do prophylactic surgery.
On this first question, Dr. Knost, I think they want to know what causes the good gene to fail. So if they have one bad copy, what causes, so we already know that gene's failed, but what causes the good one to go bad?
Well, that probably has to do with ionizing radiation, free radical formation within the cell, exposure to carcinogens, all the things that, we're exposed to on a daily basis, has the potential to damage them. If you have problems repairing and the key protein in the repair process gets damaged, and you have two copies, one's bad and not working, the second one gets damaged in any way, shape, or form, then the very damage of that prevents it from repairing itself. So that's what happens. You have one good copy, you're going through life, that one's injured, then you begin to pile up the mutations. So this question addresses an issue that has to do with Anne, who was a BRCA positive and wants to know about being tested for that. And this is a point that we try to make in the clinic, and that is, if someone is tested and they come up with abnormalities such as a PAB2 abnormality, okay, or CHEK2 or one of the others, BRCA1, BRCA2, that panel, to begin with, usually costs about $4,000. But if you want to be tested, you only need to be tested for the one abnormality, the one mutation. You don't have to be tested for all the genes on the panel. And for instance, Henry has a policy that an out-of-pocket maximum for an additional family member would be $100. So if you have a relative, they have a positive genetic abnormality, and you want to be tested, it's not a $4,000 test. In most cases, it's somewhere between $100 and $300.
One question I have here was that someone heard that I will not remove a healthy breast. They're correct on that. What is a healthy breast? A healthy breast is not a genetic mutation breast, right? That breast is not really considered a healthy breast. It has a problem, and in all likelihood, that patient, if she lives long enough, is going to be experiencing cancer. So we're doing prophylactic surgery on a patient that has a mutation, like we talked about, is considered appropriate treatment. It is an acceptable treatment by insurance companies to pay for. Trust me, they're not going to pay for something unless there is really good guidelines that there is benefit to doing this for them and for you. Where I differ on, or when what probably they're talking about are patients that have a cancer, or maybe don't have cancer and just have lumpy breasts and want the breasts removed. Prophylactic mastectomies are not minor surgeries for patients. Removing breasts without pathology in them is really not appropriate in most cases. There are some very few cases where it might be appropriate, but to be honest, I can't come up with too many of them. In most cases, patients are fearful, and they just need to be reassured that with proper follow-up, we usually can pick up cancers early if they're going to occur at all on a patient. One of these was, do I feel differently about the BRCA gene? Sure, just like I said. And if someone has cancer in one breast and they have the gene, usually they're having both breasts removed, but sometimes they don't want their breasts removed, they just want breast preservation. I don't know if I'm answering those questions good enough for the person that wanted it.
Okay, this question has to do with something that you may have thought about, and that is, why is it that someone with BRCA1 had breast cancer in their 30s and others have it in their 50s or 60s? And it certainly may be what they're exposed to, but there are, because of the technology, we can begin to look at the subtle differences between the members in the crowd here. We can discern what makes you you and what may me. And there are what are called single nucleotide polymorphisms. And these are changes in the DNA which don't change the production of a protein, but they change how the protein may function, and not completely shutting off the function, but making one person have a protein that's a little more efficient than the next person. So there are a whole area of what are called modifying SNPs in patients with genetic abnormalities. The most work is being done in BRCA1 and BRCA2 because it's the largest population at the present time. But I think in the near future, there will be modifying SNPs that we will be doing on patients with BRCA1 and BRCA2 to refine their risks. Right now, our risks are based upon the past experience with young individuals over a lifetime. Now, so I think that that's what's in the near future. Along those lines, if you want to go to a website and kind of get an idea of what the manipulations would be if you have a BRCA problem, The Stanford University has what's called Stanford BRCA calculator. You can find it on the internet, and it'll allow you to ask some of these questions. Is what would it mean if I'm a particular age, have a particular mutation, and I choose to have a mastectomy, or I choose to have the ovaries out, or I choose to have MRIs. So that's a source you might keep in mind.
Next question, two of them. One of them had to do with whether I would give tamoxifen to a 34-year-old with breast cancer, or that does not have breast cancer, but has a sister diagnosed with breast cancer at age 37, HER2 positive, but BRCA negative. The use of tamoxifen as a chemopreventative drug has some pretty good guidelines for us as far as trying to determine someone's individual risk. And there are different models we can use to look at risk. Dr. Knost actually has more sophisticated models than most of us are using. But basically, we run those models on the patient, and at age 34, my guess is that by the time we get done calculating what her risk for breast cancer is, the reduction of breast cancer risk by tamoxifen may not be worth it for her. What I mean by that is, if she comes up with a risk level of 1 or 2% of developing breast cancer in the next 5 years, that would be higher than most 30-year-olds, okay? It might be 2 or 3 times higher than what the average 30-year-old would be of getting breast cancer in the next 5 years. But that's a low number, isn't it? 1 or 2%. If you take tamoxifen, you're going to reduce that by 0.5% or so. So that means that 100 women at age 34 taking tamoxifen for that reason, one might get a benefit. So the other 99 are going to take the drug for no benefit. Side effects of the drug, some people have some menopausal symptoms, although at age 34 probably not much. You know, you want to have enough benefit for a drug to make it worthwhile. And so typically when we run these numbers, the types of numbers we're talking about that patients are willing to take a drug for are usually when they get a benefit of somewhere around 3 or 4%. Okay? And even that is, in a lot of patients' minds, too low a benefit to take a chemoprevention drug. So I would say that the patient should probably talk with their family doctor about this in a little more detail. They can even run the risk assessment in the office because these Gale models are available to all of our primary care doctors. And see what her risk is. If there's more family members with breast cancer, if the mother had breast cancer, sister had breast cancer, the numbers will go up significantly, and then she might be a candidate for getting a benefit with tamoxifen. Why are more young women developing breast cancer? You know, we hear about patients more and more that are young with breast cancer, but the reality is we're not really seeing that significant a shift in age. The young age, the percentage at ages has been pretty stable lately. We're talking the last 20 years or so. There's been an increase in the number of breast cancers, but part of that we believe is due to better breast imaging. One of the downsides in some ways is we're finding cancers that some people think we may not need to treat. The problem is when they make that statement, they'll say, well, ductal carcinoma in situ is a non-lethal breast cancer. We're over-treating it. But some of those will go on to become invasive cancers. And we can't tell you when that's going to happen. And they cannot tell you that you're not going to die if it happens before we detect it. So when these high and mighty people say we don't need to treat it, I'm like, okay, but tell us how we're going to discern who doesn't need to be treated. And they come out and flatly say at the end of the articles, they don't know who to say doesn't need to be treated. I will tell you that there is absolutely a move to back off on over-treating people. So we are trying to get away from just treating everybody the same way. We're trying to get individualized approaches so that maybe the person that's 65, 70 years old who has a very small amount of early breast cancer could just have a lumpectomy and perhaps be put on medication as a prevention. And that's it. No radiation, no chemotherapy, none of that kind of stuff. Just maybe a little bit of, not necessarily tamoxifen, but aromatase inhibitor. So I hope, you know, from the standpoint, again, of young cancers, we're not really seeing a big shift. There are young cancers. Some of them are, a lot of our young ones have been genetically positive. So percentage-wise, it's certainly higher in our younger patients. So that can explain it. And there's probably genetic abnormalities really that we have not discovered yet.
All right, this question has to do with leukemia. Check 2 are they all the same, and leukemia is a familial or family-related loss of function of p53. Now, p53 is a very important molecule, and it regulates cell division, and it also tells the cell if it's injured to stop, assess whether or not it thinks it can recover, and then try to recover. If it doesn't think that the cell can recover, then there are a series of events that occur in which certain enzymes are released on the inside of the cell, and the cell dies. So p53 sits there as a brake on cell division. If you take off the brake of the cell division, then the chances for mutations increase because you have an increased number of cells that are dividing. Check 2, on the other hand, is a part of the complex that I was talking about. In the process of repairing damage to the DNA, which we all face every day, we use check 2 to facilitate the functions of the BRCA1, BRCA2, and the other complexes that are trying to repair damage to the DNA by repairing both strands at the same time. So, no, they're different diseases. Leukemia is a devastating disease in which there are a multitude of malignancies that occur, and check 2 is predominantly breast and colon and a few other diseases occurring at a later age and having a different profile.
There was a question here about a young girl, age 10, whose mother and grandmother had breast cancer, and what would be the process for this young woman? Again, we would not incur, unless there's a family history that would suggest leukemia in the family, we would not suggest any testing of the young girl at that age. We would wait for her to mature and be able to participate in the decision-making herself. The question I would ask is, if mom is still alive, and if mom was relatively young and her mother was relatively young, the mother should be tested, is what we would recommend. We recommend testing an affected individual, if at all possible, the youngest affected individual in the family, if there's a series of people within the family. It says here, if her chance for getting breast cancer is 50%, it's only 50% if mom had an abnormal gene. So we need to follow that pattern first. You need to find out if mom has it, because if mom is negative, then she's negative, okay? Yeah, that was it. I wrote some things to myself.
Planning your own questions, I like that. Okay, this has to do with the daughter is 16 and at what age should be screened. In general, we wait for the individual to get to be 18 years of age so they can participate in the screening process. So that's the answer to that. And she has a BRCA1, her sister is negative. Sister has the same risk as anyone else and would not qualify for yearly MRI scans. And there's a question about birth control, and we like to start that, after the age of 18, because birth control pills do carry their own risk, blood clots and so forth. So I think that's the answer to those 3 questions. Unless she needs it. Okay.
This is your daughter. All right. How young do you recommend prophylactic mastectomies in BRCA1, BRCA2? We kind of covered that already, so we won't do that one. Once someone is aware of a genetic mutation, what decides whether they should receive surgery or not? Again, they have their initial genetic counseling with Dr. Knost or another genetic counselor, and they are usually referred to the appropriate surgeon to discuss whether or not they would like to consider having surgery. When a BRCA patient is sent to me, that patient becomes my patient from now on.
So even if she has prophylactic mastectomies, I follow that patient because remember I said it's a 90% reduction in cancer. It's not 100%. So these people need to be followed closely. And really, it's a very personal decision by these patients whether they want to have prophylactic surgery or not. It's not really a set age, but certainly if their mother had, for example, ovarian cancer at age 40, and they have the same mutation as their mother, we would like to get those ovaries out perhaps before age 40. You know, so those are discussions that are had with the patient, and when they're ready to have it done, we have it done.
All right, this question has to do with the use of tamoxifen in someone that, well, first of all, BRCA, if you look at the BRCA abnormalities, BRCA1, maybe 80% of them are triple negative and 20% are positive. 97% would be infiltrating ductal, the other 3% would be lobular. If you look at BRCA2, it's just the opposite. About 80% are ERP positive, and about 9% of those are lobular, the rest are infiltrating ductal. So it's sort of a profile of the groups. But the question is, if you're BRCA1 and triple negative, how do you benefit from prophylactic tamoxifen? And that's a good question, because in the original study where we were using the prophylactic tamoxifen, they took in all women, and this was at a period of time in the late 90s, in 2000 or so, when BRCA testing wasn't being routinely done. So the National Surgical Adjuvant Breast Project went back and looked to see if those women that had BRCA abnormalities would benefit. And that's where the information, that's where some of the information came from. There was a recent study within the last couple of months to show that in a larger cohort of BRCA patients, even BRCA patients with BRCA1 did benefit. The idea is that breast cancer is a transition from normal breast tubules. Well, let me back up and say that the breast basically is made up of two components as far as cancer is concerned. That's the milk globule, and then the milk globule is drained by these tubes to the nipple, and the tubes are called ducts. And so you have either lobular from the milk globule or from the ducts. And so the transition that you have in infiltrating ductal is from normal cells to tumor cells to atypical cells to ductal carcinoma site to breast cancer. We think that there is a transition from DCIS that's ER positive to patients that drop that particular gene and become ER negative as they transition to a malignancy. That might be the explanation, but right now we don't have a good explanation for that observation.
When testing, screening of a lady that has had breast cancer, both breasts, are all the mutations tested for?
What's that? Oh, okay. Well, the answer to that is that the panels differ in the number of genes that are put on the panel and the number of things that are tested for. And as an example, at the present time, we don't know if the gene XRCC2 leads to an increased risk of breast cancer. There is some information out there to suggest that that might be the case. And this is a particular enzyme that's necessary for a different way of repairing the DNA. So we talked about homologous repair, where you can repair both strands at the same time. And there's another way, another system, which will go down the DNA and it'll pluck out the A, the adenine, the little red tube, and correct adenine mistakes as they're being made. And so the XRCC2 makes this particular process work more efficiently. Theoretically, this should have increased risk of breast cancer. We don't know that for a fact. So the panels differ. The University of Washington puts XRCC2 on their panel, but with several other particular genes that are not clearly associated with increased risk, whereas Myriad, GeneDx, and Ambry have a more refined panel that has the genes which I mentioned at the end of my talk. So the ones where we can pick out a gene and explain the 10% of patients that have a genetic reason for their breast cancer, those are on everybody's panel. BRCA1, BRCA2, CHEK2, ATM, P53, and so forth. Yeah. does the self-referral with the insurance pay for it? And the answer is yes. It really doesn't matter. I mean, it's important that you have parents or relatives that have breast cancer, but it's not a criteria for the insurance company to pay for it. Okay, real quickly, are you saying that the change, that we can fix the gene? The answer is no. My example was the normal process of repairing damage, which we all face on a daily basis. If there's a problem with that process, then it leads to an increased risk of cancer.
There's one here that has a very nice family history. Thank you for being so specific about family history. Lots of strong family history for breast and ovarian cancer. The mother had breast cancer at age 58 and ovarian cancer at age 50. Died of breast cancer at age 60. A cousin and aunt had ovarian cancer. The mother did have genetic testing done, but it was done before or done around 1999. It was negative for BRCA1 and BRCA2. At that point, they would not have done BART.
That's right.
So it says here a cousin that has had breast cancer since also had testing for BRCA1 and BRCA2 and was negative. I don't know what age that cousin was, but I would think that this woman would qualify for genetic testing just based on her mother and her other family history, since her mother is not able to be tested now unless they have samples left.
Yes, no, she would qualify for testing.
She would qualify for testing. So I would consider getting tested with the current testing parameters now.
Great. Well, thank you very much. I want to really express our gratitude to all of our panelists for participating and for each of you for coming out this afternoon and participating in our first lecture. And also want to thank Myriad Genetics. Really was very instrumental in helping us financially support this lecture. Unfortunately, their representative couldn't be with us, but we appreciate their sponsorship of this event. And I'm sure that our panelists will stick around for a few minutes. If you have some personal questions you would like to come up and ask, that would be wonderful. And then would also like to just remind you to be sure to give us some feedback about the program today to help us in future programs. And with that, I think that's all there is. Our next lecture will be held on June 5th at 9 o'clock in the morning at Caterpillar headquarters, and we're going to put on a program about supporting cancer families and cancer patients and their families in the workplace. So with that, we're adjourned. And again, thank you so much for being with us.
Yes, I can shut it off. Are you collecting these?